Good morning, everybody. It is so good to have you here with me. Imagine
if you have your vision as the car with the right team.
Imagine how quick that vision will come into the picture. Something that was taking 5 years takes 3 months. This morning is all about the leadership and influence. There we go again. Good day, everybody. It's so good to be with you again online on the Inside Show. What a great honor and privilege to have you online here today. And today we have a wonderful subject here, a hot topic in South Africa and worldwide around the vaccines. And the question that we posed this morning is simply, what's happening with the vaccines? There's such a lot of issues around this subject, and we're really going to dig into it. And I've got such wonderful people in the studio. I've got Neil Hudsenberg on the studio here as a co-host this morning. He will pose some questions, and he will intervene and ask some difficult questions to my panel here today. And then also I have the Honorable Mr. Ivamectin in the studio here with us here today. And then also our insights doctor, if you may call her that, Dr. Mary Adam. A warm welcome to you all here. We're gonna dig in immediately around this Inside Show, but before we get there, I just want to welcome Mr. Farnell. A warm welcome to you, and any early things that people can expect in the show. So you're more than welcome to most probably just mention something there. I just want Pastor Neil just to put his phone a little off there. It's on there. It's causing an echo there. Yeah, thank you so much. So, Mr. Farnell, just give us a shout out what to expect in the call, yeah.
No, it's going to be a bumper show. Thank you, Doc, for the invitation. Always nice to be here. And we're going to have a look at the management. We're going to have a look at some of the challenges around this vaccine. It's a question of distribution, credibility. Was the proper trials conducted? Is this thing safe? Can we get it to the people? Is it the proper strategy? There's a mouthful waiting on us this morning.
I can't wait. South Africa, we are ready. And then on the other hand, the other question that so many Christians are asking, they wanted to know, how safe is this vaccine? And is there a 666 in the vaccine? Is there a chip in the vaccine?
Can we trust Justice really let the cat amongst the pigeons? Eh?
Yes. So this is the things that we're going to discuss today. And if you want anybody to know about the show, I want you to just please phone a friend up or share this link with a friend. Put it on your Facebook platform or any media or platform that you have. Just get it out there and let us just have a quick discussion around this vaccine. It's the first of, I think, many rounds here. There's a lot that will take place. But this morning, without wasting time, I want to get the doctor on the line immediately here. And my question to you is, what do we need to know about the COVID-19, Dr. Mary, and the South African variant? If it comes to the transmission, the new symptoms, the testing for the virus, the nose versus the back throat, antigen versus antibody, and can school going be affected? So that was a mouthful, but I know you can handle that. So give us your views on it.
Thank you so much, and good morning to everybody, both listeners and viewers. It's always a pleasure and a privilege to be with you and to share information. And that is so critical in this time because we need platforms to share honest and truthful information with regards to COVID so that we can together move forward and together save lives. It's not only about us in the healthcare system, it's not only about scientists, but it's a collaboration between many entities to bring us to this point. Just to unpack your question, it's quite loaded, but essentially, just to give a recap on COVID-19, I'm sure we're all aware of it since this started in December 2019. It is an acute respiratory syndrome from a group of coronaviruses. And we've seen the first viruses in 2002 with the SARS virus, which is the severe acute respiratory syndrome. And that originated from a caveat cat. In 2012, we saw the MERS virus, which was the Middle East respiratory virus, and that originated from camels. And then now in 2019, we saw a novel virus. And when I explained it at one point, I said it's like when you're at a family gathering and then you see this cousin that's out of hand, and yet you don't know who that cousin is. And so you keep on asking, who's that cousin, just to get more information about that particular cousin, because it's completely out of hand. The dress code is not there. It's never in the photos. So how do you know who this particular person is? So the same with the coronavirus. It presented as an atypical respiratory infection. And this, they suspected that the origin came from what we call zoonotic disease outbreak, particularly from a fishing market in the province of Wuhan in China. And so in December 2019, it was alerted that there's this global outbreak, and that's when we all sort of became alerted to it and started to pay attention to it. And then in South Africa, particularly in February, that's when the medical fraternity and scientists really started looking at what is happening across our borders as well as across the world in order to understand how this would impact us, because the Northern Hemisphere, this atypical respiratory virus spread rapidly. And now when one looks at the structure of the virus, and this is why it's important when we come to the topic of the vaccines, and we'll touch on it a little bit later, is that it looks like a crown. And so, or the spike proteins present itself, and the way it looks like a crown sort of structure, and that's where the name also comes from, Latin corona, crown. And so it's in that structure and spike proteins that allow it to bind to the host cell, and that through a receptor in the cell allows it to get into the human host or the host, and therefore causing respiratory symptoms and therefore transmissibility. So how does the actual virus do this? And as you had mentioned in your question about the respiratory, the nasal swab versus the back of the throat swab, because what happens is that with the virus itself, when it's in a droplet form, and what happens is that it actually then comes through the nasal passage, because that's as adults, that's how we sort of breathe in, and this particle then sits in the epithelial, which is the layer inside the nose, and the layer of tissue around the nose, and it then uses what we call an ACE2 receptor, and those spike proteins then attach to that ACE inhibitor, and it creates a portal, a transport into the cell. This then goes into the back of so it starts in the nose and then goes to the back of the throat. Therefore, you get these two sort of modalities of testing. Through the nasal, the anterior canal, and then you can see when they open up the mouth, they test at the back of the throat. So that's why you'll see now mostly we've moved towards the nasal testing, because also patients or individuals are able to do the self-testing themselves. So then what happens from there? Most people, about 80% of people, can actually then, from that point, the immune system already recognizes it and it tries to contain it, and then it sort of gets contained, and about 10 to 14 days, the person, even asymptomatic, does not present with any symptoms. But if there's continuous viral replication, depending on the host's or the person's immune response, and this then moves from the nose to the throat to the conducting system, which is now the back of the throat, to the bronchi, into the alveoli. And as the replication, so replication is how now it's using the host to multiply. And as it multiplies, it now looks for this ACE2 receptor in different tissues. But particularly with COVID-19, the preference here is the lungs. So it gets into the lung tissue, and it sits, it actually then uses that ACE2 receptor, gets into the lung, and as it's doing that, it continues to replicate. But as it's replicating, it's also then moving from one of the normal cells to, or let me rather say healthy cells, to continue doing its job. In the lungs, there's a particular cell, it's called the pneumocytes. So it starts damaging the type 2 pneumocytes, and the type 1 pneumocytes. Now, why is this important? And this is what leads to some of the symptoms that we see in terms of the shortness of breath, difficulty breathing, because those cells, the type 2 pneumocytes, actually help in terms of producing what we call surfactant. Now, surfactant is it produces it allows for the alveoli, which is like an airbag. If you can imagine a balloon, and now that balloon, it needs to be able to stay open, and so the surfactant allows that to happen. So it allows for recoil and expansion of the lung cell. So now,
Dr. Mary, if I may just interrupt there. That was a mouthful, because that was clearly from a medical perspective, and I don't blame you. You're a medical doctor, and we expect you to give us the facts. And that's exactly what it is. There's a question from Mr. Fanel that he would love to pose. But before he asks that question, I just want to know exactly about, can school going be affected in this whole situation? What's your take about the school going? Because we just opened schools yesterday, and the parents are so excited to bring their children back. Just on that one, before I get to Mr. Fanel.
So, what's happened with COVID and what we've seen in the past is that with the age, if you remember, we looked at 65 and above. It had a particular age group, and a particular profile. So we looked at 65 and above male persons, and so that was what the typical profile looked like when this in our first peak. And then as it was going lower into the trough, we did see it affecting school-going children, but not symptomatic. And that's why in terms of how the virus actually works is important to understand. But when you look at the kids, they're less likely to present with symptoms. So they can be carriers, but not necessarily become sick, as we see with the older population. So
I wish I was a child. I wish I was a child. Dr. Mary is like man, such a great privilege and honor.
They can have symptoms, but they might have a milder form, and they're carriers. So, and therefore, you would see in the second wave, from what happened in December 2020, the main group of individuals that were affected were from 14 to 20. So some of that are still in the school-going age. But what was significant about that, and what is important, is that was through super spreader events. It wasn't from attending schools. And why is that important? Because at schools, they adhere to regulations more strictly in terms of when they actually come in, they do the screening, they do the temperature, they check that the children have masks, and they also advocate for hand washing. So, yes, I don't. You know,
right, a question to you now from Mr. Fanel.
Okay, Dr. Mary, I think you presented us with a really good foundation this morning. Pure facts, truth. I like the point you made when you started talking, when you said what we need most in this pandemic is truthful, reliable information. And of course, that is one of the purposes of a show like this, hosted by Dr. Hendricks, to find reliable information. And some of us have been characterized as naysayers, doomsayers, conspiracy theorists, merely for challenging the credibility and the truthfulness of information. Now, over the last 2 months or so, the obsession with the vaccine has overtaken us all, not just here, but also globally. But I want to take one step back. What about other reliable medication that was on the shelf for decades, that was accessible for decades, that suddenly became contentious in the COVID context? Just early in this month, some doctors, so this is not outside commentators, this is not lay people, this is not ignorant people contesting what is supposed to be a holy grail medical information. They took SAPRA to court, and they actually succeeded in getting a court order in the North Gauteng High Court compelling SAPRA to permit doctors to dispense ivermectin. There's others as well. There was a Jamaican doctor last year that was later blocked by YouTube and Facebook for advocating hydroxychloroquine. What happened to those type of reliable medication?
The question. And yes, indeed, at the beginning of COVID, because it's a new virus, a new strain that came onto the scene, obviously there's no particular drug that would be able to cure or treat such a virus. And so one would need to do adequate research and checks and put that in place to find out, is it safe? And is it a quality drug for this particular treatment? And so you will see that there's no one treatment that was actually given globally for the treatment of COVID-19. And so what it is a combination of treatments in order to treat the symptoms, particularly of COVID-19. And so that is where the challenge comes in. So then you would have groups of individuals, groups of scientists, groups of doctors that would use in their practice and say, you know what, this drug is better than another drug. So that's why you would find that some people would come out forthright and say, I would use this particular drug and it works for my patient. But you would find that it is within that particular population that that particular drug works. Now let's look at the hydrochloroquine, and that was part of the treatment in terms of the combination of treatments in order to help and facilitate the treatment and survival of patients. But most people then had come out and said, it is the cure, it is the drug. And that is where we need to be careful. We all need to speak the same language when it comes to the treatment of particularly new drugs. Let's look at ivermectin. Ivermectin is a drug that is there. It's FDA approved for the treatment in veterinary medicine. What does that mean? It's used for the treatment of parasites in animals. So it's there. And so what they do, and that happens in medicine where you do have drugs that are available and we can use them off code for particular medications if it's advised to do so. And so what they did in the labs with ivermectin, they found that there is a potential to actually stop or to hinder the progress or the movement of, not movement rather, let me say to hinder it has.
You are in a very hot seat this morning. Let me make your seat hotter. Let me make it hotter. I want you to comment on two statements I want to make. The first statement I want to make, the management of COVID has exposed the fact that medicine is not an exact science. Otherwise, the international medical community would not have been as divided as they are on our response. That's my first statement. My second statement is, having neglected these other groups of medicines that could respond to specific symptoms was not the outcome of ignorance, but it was well calculated by certain governments and big pharmaceuticals, because you can't milk the billions out of them that you can out of a vaccine. That is why all of the focus is behind the vaccine, and we have discarded other helpful medication. What's your view?
Putting out there, and it's one that has to be debated, and openly so. And as I've mentioned before, that it's not that we've disregarded any medication, but we've said, what can we look at to actually improve the medications that are available? And just to come back to the point to actually say, when you had mentioned ivermectin specifically in terms of bringing the court into play, and this was because and we look at SAPRA. SAPRA, we can't necessarily say that they've lost the case or they've won the case. What they've done is they've said that they've given compassionate use of it. And this is to allow for families and for physicians who want to use this particular drug to actually then say they've tried every means possible to actually then use this in this. And this then brings into the question to say, okay, what is our stance then as a medical fraternity? And it's to say that we're not divided on certain issues. What we want to say is that we are open to debate, and we're open to look at what is cost effective. We're looking at what is going to be equally available. So we're looking at distributive justice as well for the majority of our patients. And number two, we want there to still be respective autonomy for individuals, patients, and physicians to think. Is medicine an exact science? It's not, and I'm not going to say it's not an exact science. I'm going to throw it out there and say it's an evolving science, because that's what happens. If you
COVID brought humility to all of us.
Yeah, no doubt. No doubt.
COVID brought humility to all of us, including all of sides.
Yes.
That is my issue. That is my issue, doctor. Let me get into the crux of it. If the world, up until now, could have never given us a vaccine for HIV or TB, which has been plaguing the world for decades, and wow, boom, suddenly, in less than 6 months, we have a vaccine for a fairly new phenomenon, right? Where was that same investment, that same clinical trials, that same focus? For example, Ivamectin, since April last year, where was that same commitment to say, let us explore other groups of medicine that can be used for symptomatic response in the meantime? Why did we take all the money, all the focus, all the research and put it in producing a vaccine in record time, while we paid scant regard to looking at our other options?
Okay. I can? Can you hear me?
Yes.
We can hear you.
Okay. So no, yes, and this is a valid point that one would look at. I like how you say that, no regard was put into some of these medications that have been, that are there on the shelf. Yes, that are there, that are on the shelf. I'll start with that point. When COVID-19 was obviously made as a global pandemic, already from Wuhan, from the patients that were there, already research had already started in terms of what is this virus, how is it transmitted, how is it becoming a global how it actually then spread throughout the world. And so every country then had to come on board and had to sit at the same table to actually then say, how are we going to curb COVID-19? Because we've seen that immediately as it had spread from country to country, it was spreading, the numbers were increasing, death rates were increasing. So research hadn't stopped in terms of now, it hadn't come to a halt. So from those Wuhan cases, already we had ideas of what was potentially happening with this virus, what were potential medications to use. So yes, in the media, you might not get all the information to say that, you know what, this is what's currently there. This is what's currently there. And so therefore, some people will use platforms like Facebook, Instagram, all these social media platforms to bring out their point of view without the view of the science fraternity coming out. Because if you have to go and do a Google search and go to see what was being said about certain medications that we've mentioned here, you will find that already research had been done about that. If you have to call up STAPRO, which is our medical regulatory system, I'm gonna keep on using ivermectin because it's a hot topic at the moment.
Yes.
Ivermectin was discussed, and you will see that they have continuous meetings and updates with regards to current medication that's potentially used. For example, when Italy had found itself in its first wave, they were already trialing out certain medications. But I want to take it a step back. You can even argue with the issue about oxygenation of a patient, because even when in the USA, in New York, when they were debating the issue of using invasive versus non-invasive use of oxygenation, that means for our general community, the use of intubating a patient. Should we be intubating? Initially, there was a strong outcry to say no, because they found that there was an increase in mortality, that is in the death of patients when they were given oxygen via the tube. So where are we now? Through research, through continuous engagement with science, with the pathophysiology, with the change of the virus, we've actually then said we need to relook at our protocols. Now coming to a point of the vaccines. So South Africa, and this is where we have to credit technology and science, because what has happened is that as the testing had been taking place, we weren't just sitting back waiting for the international scientists and science fraternity to actually tell us what is actually happening with the virus. We were actually looking at what is happening with the South African population, what was happening with the changes, because when we talk about variants and strains and mutations, that happens with every virus, with every bacteria, because it needs to survive. So already genomics, which is the study of the changes in the virus, already that had been happening. And that is how we come to the point of us saying that we've already identified. Mm-hmm. So, all of that information, when did you as a public get to know about, the new variant? In January or so, but this was already been discovered from the beginning of March 2019, that there already different strains have been coming out.
Dr. Mary, just tell me if our viewers watching today, if they ask us about the Ivamectin, and they ask you a direct question, is it safe for me to use it? Can I use it? And what's your suggestion towards that? It's a simple question, and I think people are starting asking that question. It's like, can I go out and get it for me because I'm scared? I want to prevent. Will this help me? Yes or no? What will there? Is it? I know there's no yes or no, but through your lenses, what would you say?
So for Ivamectin, for its use, it has to be still regulated in the setting that it's used. And so an individual who's asymptomatic, mild or moderate disease, one does not need to take Ivamectin. Where it's been suggested that it's used is in our critically ill patients, so that's patients with severe disease, those who need oxygenation, and those in the ICU settings. That's where the need for Ivamectin is. And so it's, again, in combination with other medications. It shouldn't be seen as a miracle drug, and that's what we need to emphasize.
That's good. I like your answer, and I tell you, I know you are sitting there, and we're asking Dr. Mary questions here. That's really a bigger platform that should answer that. But we're just too glad that you're helping us out here, because we are sitting there on the other side and we're not sure what's really happening here. Dr. Mary, just to speed time up, because we just want to get into a few other things, and I'm going to get you off the hook. I'm very mindful that you at your workplace today, and thank you so much for taking time out. Dr. Mary is a medical doctor at Baragwana Hospital. Just quickly around the vaccine saga, specifically around what was the rush and why did it get to be produced so quickly? What was the rush, and specifically around that issue? Can you most probably just explain that? Most probably not about the vaccine, but more the rush about getting the vaccine to South Africa, and we didn't get it right even in the case of the vaccine from India.
Yes. Thank you, Dr. Carl. And this I'm going to include with our esteemed guest, Apostle Atianel, because he mentioned also about the vaccines, and one thing has to realize, and I mentioned this as well, is in terms of technology and how far we've come with technology. That's the first thing. The second thing is, yes, there is what we call, so we've got anti-vaxxers, which are people who are totally against vaccinations, but then there's also a group of people who are vaccination hesitancy. So that basically is a group of people who, initially when you say, a vaccine is produced in 6 months, you go, is it safe? like how is that possible? But that we have to credit to the processes that are in place. It doesn't mean that any of the steps required in the development of a vaccine have been skipped, because it still needs to maintain the three pillars of developing a vaccine, which is safety, equity, and quality of a vaccine. So those pillars need to be upheld. Yes, in the past, it can take you anything from 5 to 10 years to make a vaccine. But with this vaccine, it's literally taken 6 months. And this will come now to Apostle Ati Fanel's point about how quickly, why did this happen so quickly? And the reason that happened so quickly was because this is a global pandemic. And what had happened, as you had mentioned as well, is that it really humbled everybody, whether you had deep pockets, not so deep pockets, and empty pockets. Everybody had to come to the same table. And so what happened is it formed this COVAX facility. And in this COVAX facility, it allowed for the negotiations of different countries to take place, and allowed from high income to low income countries to have access to vaccines. The next point is that there was a public and private investment into such. This bringing your high income and low income to put everything onto the table. And so there was this collaboration of cooperation, and so there was a lot of buy-in from a lot of people.
Now, can I throw you a curveball? HIV/AIDS is also a global pandemic. HIV/AIDS also does not distinguish between class and geographical locality and gender and literacy levels. It is also ravaging, especially the global south, as is tuberculosis. One of the things that COVID has done was to take the focus and the investment into something like TB and put it on the back shelf, while TB continues to be a real killer. If you currently look at South Africa for the top 10 reasons of killings or deaths over the last 12 months, COVID comes in at number 11. It's not even in the top 10 yet.
Yeah.
But it consumes.
Yeah, Mr. Fanel, I hope you ask that question as a general question, because it's going to be unfair to pose that question to Dr. Mary.
Yes, no,
because,
of course, no.
But you're really posting it out there because it's relevant.
I want to take on it.
Yeah.
Yes.
You want to quickly?
Yeah. And the good thing about who you invited here,
Yeah.
she's not just knowledgeable.
Yeah.
She has the ability to transfer that knowledge.
Okay.
Not all people have both.
Yes.
If I didn't know her, I would have suspected she goes to church at Crystal. So they produce some well-spoken people around here. I don't know. I just my suspicion. So.
Mr. Fanel, I just want to mention one thing to you. We're sitting on 9:37 here.
Yes, sir.
So we have a battle with time here.
Yeah.
And I just want to get back to the vaccine and not most probably around all the other stuff, if you don't mind. And most probably we must get Dr. Mary back online here. And I know she's knowledgeable. And I know you're itching there, but I'm also itching to get other questions in here.
No, it's fine.
Yeah. Dr. Mary, is there a possibility for a third wave? That's more my question. Is there a possibility for a third wave?
Yes, there is. There is a possibility of a third wave and a fourth wave. And the reason why I'm saying this, I know I can see you.
Did you say there's a possibility for a third? You know what? Oh, God have mercy on us. I don't know about you, but if you want to send us some questions, please be so kind. We've got Dr. Mary in the house here, and she will answer all necessary questions according her abilities and for where she is now. And but just to hear that there's a possibility for a third and a fourth wave, I mean, that is something that I didn't expect you to say. Most probably the third, but not the fourth.
There's a possibility of a third wave, and this is more coming. We need the science, obviously, to back it up. But if we look at the current patterns of what we've seen, it's that we become relaxed as a nation, as a population. So what will happen? We get the vaccine. and then we relax. We think we don't need to wear our face masks, our hand washing, our social distancing. We neglect that, and that is essential still in curbing or flattening the curve, because the transmission happens person to person, host to host. And so we'll get the false sense of security when we get the vaccine, and then we'll become too relaxed, and therefore we might actually then see a third wave. It might not be as dramatic as what we've seen now with the second wave, but certainly we can anticipate it. And the other reason why we can have to anticipate a third wave is that we'll go into our winter season, and we've seen this with the other countries. As soon as they went out of their winter season, went into the next winter season, that they actually then had their wave.
The question came through. Good morning.
And it's just, is that, am I allowed? Maybe 1 second, just 1 second on this, Dr. Carl.
Yeah. Go ahead.
It comes to the point of the HIV, because this one, and TB, and this comes to the development of the vaccine. And this comes to the issue of vaccine hesitancy.
That's why I raised it.
Yes, and this is the second time you're raising it. So I think it's something that's also on the minds of the people. I was going to come to it. What is important to realize is that with the HIV and the TB, the mutations that take place, make it render it difficult to actually, come to a conclusion on the vaccine. So we continually also with research, it's continually evolving. We see, for example, in Congo with Ebola, one can also argue with regards to the vaccine. One can also argue with, and again in West Africa, with bringing in Ivamectin, where they used Ivamectin as well in a human host in the 1980s. And to cure what the term was river blindness. So that again was used for not an animal host, but for a human host. So again, can you see with medicine, it continuously evolving. With the COVID vaccine, the reason why it also, the last point on why it was developed so quickly was because as the swabs and the testing was going in and they were looking at the genomics, they were able to predict for that time what was happening with the vaccine, with the spike proteins. But obviously they knew it continues to mutate, so they were going for the dominant structure of the virus. So that's why when we come to the topic of the variant and is it effective and what was the rush, we'll come to that, because that is also important in terms of the hesitancy, losing faith in our government, losing faith in our health ministry. All of these are important to understand. And therefore, when you say at the end of this, am I going to take the vaccine? One would then actually say yes or no based on that information.
Thank you, Dr. Mary. Dr. Mary, I have a question. Good morning, and thank you so much for your input. It's really valuable. This morning, the question goes around the efficacy of the vaccine, and specifically the question asks, will we have to take the vaccine continually like we do with a cold and flu drug, or will it be a once-off? Once you inoculated, you are then immune to COVID-19?
Yes, so vaccines, because of the mutation, let me start with this from here. So yes, we'll have to take a vaccine in order to help curb the spread of the virus and to stop it in its tracks, particularly the dominant variant of the particular season. And therefore, one would have to look at, now we're looking, is it a single dose? Is it a double dose? Or not a double dose, but a dose separated by particular weeks. So if I can use, for example, with the AstraZeneca one, that the dominant variant that it was going to cover, it was going to be a 2-dose. So it means you take a dose now, and then one either
you take another dose when it expires.
Yes, so okay, that one we need a whole show on its own, because that, we need to now bring in who forced, because I'm going to use that word, who forced us to take that vaccine? Where did the pressure come from for us to get that particular vaccine?
And we made ourselves as an international public spectacle with that, eh?
Yes, no, it did. It did. But where did the pressure come from for us to get that particular vaccine? When in South Africa, we have 3 trials running that are close to completion.
Public relations. That's where the pressure came from. Public relations. Our government was under severe pressure to demonstrate that they are able to do something. And that something that they had to do was nothing. But as long as we had the photo op, when it arrived here on the 1st of February, that was our preoccupation.
Yeah, I'll take a deep breath on that one because I don't think it was only about a photo op. I think really the good intention was to make sure that we also start with our vaccination and the rollout, and importantly to curb or flatten the wave.
Here's the bad part, Dr. Mary. Here's the bad part.
That we have to realize that in our population or in South Africa, our capacity to manage, moderate to severe disease, we're not at the same standard as international standards, and we're really doing our best to do so. So one way to help us cost effectively curb this and to reach our population is through a vaccine. And that is the unfortunate part, that the checks and the tick boxes were made. But unfortunately, when that vaccine had left, because we cannot discredit AstraZeneca, because in India, they only have this what we would call the current strain, the original strain, if I can put it that way. Whereas in South Africa, we had now moved from that original strain to a new variant.
Here's the sad part. 2 weeks after we realized that we bought an expired consignment, no one is suspended, no one is investigated, not a single head has rolled. The very same people who bought 1 million expired dosages is now buying 20 million from Pfizer, 9 million through COVAX, and 12 million from another supplier. But here's a direct question. Does taking the vaccine automatically translate to being inoculated? In other words, for the purposes of the viewer, if I take the vaccine, can I relax in the knowledge that I now no longer can contract the virus?
So when you take the appropriate vaccine, that's what one has to understand, is that one is then covered for that mutation or for that strain or for that variant. So that is what one has to understand. And therefore, we said we'll halt the AstraZeneca and we'll go for the Johnson & Johnson, because then we are then targeting a variant that is then currently in the country. So it means that, yes, you would then be covered by the vaccine for that. If one comes into contact with a person with COVID-19 with a different strain, you will be able to contract that strain. So you're not covered for other strains, but you're covered for the strain that you're being vaccinated for. This to Pastor Neil's question about having boosters changes every year, because the virus wants to survive from host to host. So it's going to continue mutating. So every year, like the flu vaccine, we'll have to get a new one.
So let's just bring the clarity in here for the viewer. So if, let's say, by October this year, there's 5 variants or strains, then technically speaking, I would need 5 vaccinations. One for each strain, to consider myself inoculated.
Yeah, so what happens is that again, this is where science and technology comes in, is that you get different kinds of formulations of the thing, and we can call them monoclonal or monovalent, bivalent. And then, so they have different thing. And this we've seen with immunization of children, where you can put into a vaccine multiple antigens, so that you can actually then inoculate just with one. So we're doing it already. So you don't need 5 shots for 5 strains. You need 1 shot with multiple. And we do that already with our immunization program for children. So if I can reassure the viewer to say, you're not going to be jabbed 5 times, or you don't need 5 injection sites. What you'll need is just one injection site, and it will be a multi-valent vaccine.
Yeah. Well, everybody out there, I tell you, I'm so thankful to Dr. Mary for all this wonderful answers, and she's really helping us. But there's a few questions coming through from public there, and I'm going to ask Neil Hudsenberg just to pose those questions to Dr. Mary.
Okay, there's a question. Is there a reason why the cases in females are higher than in males?
Perfect. Are we talking in the second wave?
Yes, in the second wave.
Okay. So yeah. So again, this is if we look there again, it's continually to evolve, and I'm using that word continuously because that's what's happening with any virus. But it was predominantly male initially, but then again, you can see in the second wave, it's changed its face a little bit, and it's then changed to the age group has widened as well as to females, but not particularly for any reason. It's just for the fact that it's more transmissible now, and also the exposure to different people.
Okay. So just one more question. There's a question that says, Dr. Mary, what's your stance on face masks? Yes or no? Whilst wearing mask, you can still smell smoke. Does this in turn provide sufficient protection from contracting the virus, or double masking?
Okay, so the masks are essential in order to protect the next person, or yourself if you're in a space with another person. And the reason why that is because when we speak or breathe out, what happens is that we can transmit droplets. So that means you actually then speaking, and spit or sputum actually comes out, and that then falls onto a surface, falls onto the next individual, and then it goes into the mucous membranes, like the eyes, like the mouth, nose. The hands become an important carrier, because what we do is we touch surfaces. So the reason why we wear a mask is then to prevent those droplets from actually spreading beyond yourself. So you literally keep it on close to you. So you're protecting the next person from actually contracting the virus. So now in terms of smelling smoke, this is for droplets. It's not for smoke and that sort of thing. So it depends also on the type of mask that one is using. So the masks that we are using are N95 masks and surgical masks. Okay, in the public, we're using what we call the cloth masks, and that should be sufficient. And probably with the person asking the question, they're saying they can smell smoke, and that is because it's most likely a cloth mask, but it's mainly to protect those particles, particularly from the mouth and nose, from spreading. And then in terms of the double masking, that is something that is also now in discussion. It's at the table at the World Health Organization and different medical science fraternities to discuss whether or not, because of the change in the variant or the mutation, and then also because of its increased transmissibility. So is it actually penetrating through the pores of that allows us to breathe? But essentially, my stance is we have to wear our masks to protect each other. So we save lives together, not just us as doctors, not other frontline or essential workers, all of us together.
Dr. Mary, thank you so much. You're so kind. Just quickly, I know some of the questions will be yes and no answers, but just on the question on the Bible, the believers on the other side, they're so scared about the vaccine. People ask questions online. Is there a chip in the vaccine? The first question. The second one that they would love to know, does this change your DNA? So most probably just give us an answer on that from the medical perspective.
So if you look at vaccines, they're in a fluid form. So if there was a chip, one would be able to see that particular chip, even if it comes in a powder form that needs to be reconstituted to a fluid. So one would be able to see if there's a chip. So when usually people also ask about that in terms of single dose versus multi-dose from a vial, that's how it can be produced. For example, AstraZeneca can come in a vial that can take out the vaccine to supply 50 people, whereas in the Johnson & Johnson can come in a single vial, and that's one way. And if you think about a chip, it needs to be underneath the skin implanted, whereas with the vaccines, there's a fluid. So if one has to now talk about, is this from the Antichrist, is there a chip, then we'd have to go back to 1706. And in 1706, have they been implanting chips since 1706? Into this. If we look at smallpox that has been eradicated, was it through a chip? Was it through an antichrist? And when we look at now recently in 2019 with humoral papillovirus, which prevents cervical cancer in women, is that also part of the antichrist? Or is that part of saving lives?
Okay.
And is not about saving of lives? Is he not a God of healing? Is he not? Don't we pray that he's a God? He's the great physician. So if he's the great physician, how is he empowering us in the health fraternity who are faith believers that we are now doing the work of an antichrist? So that's what you'd have to say about us who are in the faith. Are we now instruments of the devil?
Dr. Mary, are you and your colleagues worried about the country's ability for distribution? We have just entered load shedding again. When we take ownership of 20 million dosage of the virus, it's temperature specific. I have seen the other day that South Africa, I never knew in preparation for this show, that South Africa is part of the bottom 10 of nations concerning child immunization. More than 70% of countries with not half of our budget compare much better to us. Are you worried that we are able to distribute this vaccine safely?
Yes, there are concerns in terms of how we're going to maintain, because what you're asking basically is about the cold chain, and are we able to maintain that? So one, do we have the capacity to do it? Number two, do we have the ability to distribute it and maintain that cold chain? And yes, again, COVID has revealed our iniquities in a lot of these areas. But one of the things that our health ministry has done is identified universities in the provinces to help with this, because research happens at these and they have the facility to do that. And then what has happened, so that's the one area in terms of capacity. In terms of distribution, education in terms of the strategy and the rollout have been taking place across the major provinces in order to actually facilitate this process from university holding facilities to big hospitals, obviously to the district. So in each province, 2 major hospitals have been identified. Teaching, education, implementation on strategy and rollout has been taking place with both the previous and the current medication vaccines.
Yeah, I'm asking that question because the first ever planning meeting between the minister and the 9 MECs and the 9 provincial HODs for the rollout of COVID only happened on the 8th of January. So we are lagging far behind in the planning and the distribution. But one more question from my side. And I'm speaking on behalf of people like myself who you put under the group hesitancy. We are the vaccination hesitancy group because we object about the limited information that's available in the public space and why the government doesn't share. As we sit and have this topic this morning, you and I have no idea what we paid to India for that consignment. We've got no idea what Johnson & Johnson is billing us. We've got no idea what we paid through the COVAX facility. So there's so much secrecy. Now, one of the things, what are you hearing? Will I be able to litigate against any of the vaccine suppliers if there are side effects that are very detrimental to my health after I took a vaccine? Especially because I have not paid for it. Because government is the payer, I'm only the user.
Well, you are the payer indirectly. Because this is not taxpayers' money that is going to that, and we are the taxpayers. So you are paying for the vaccine indirectly. So also, yes, with any medication, there are side effects for the medication. And with the vaccines for COVID-19, what one can actually look at is what has happened across the world to see, what were the side effect profiles from there. And that's the advantage of perhaps why we're starting a little bit late, because then we've got that evidence and the research that's already there. But essentially, when one goes for any medication, one would sign or willingly go, because you're going and you giving your consent. You're using the ethical pillar of autonomy to go. So if you go and actually register for a vaccine, you give consent to the thing, being fully conscious and aware of what the potential side effects
But my
are.
consent certainly does not indemnify the supplier. I'm giving consent to fly safe air when I enter the plane, but I'm giving that consent on the basis that I assume they have done everything in their power to observe civil aviation rules. So my consent was never given as indemnification. So my question is very directly, am I able to litigate?
Litigating. Is it not? You'll have to raise your concern as to what you're litigating. Because certainly when we procure any medication, and therefore we have the FDA, we have the South African medical pharmaceutical structures in place that have already done the quality checks, the safety checks, and the efficacy checks. And so therefore, even when we look at, and you mentioned it yourself, is that they halted the vaccination of AstraZeneca based on the identification as they were doing the checks now to see as it arrived in the country. So that again says to us, and that's where we have to now say that, yes, they were doing the safety checks and they halted the process of a drug that did not seem to benefit us as a country. So it's again protection for us as the community. Can you see what I'm saying? So when you say you want to go and lay a complaint or make a case, you have to know what are you going to lay the case against. Let's say, for example, you take Ivamectin. Now, you in ICU, and your family say you are so sick you cannot make that decision. But now they give you Ivamectin, and Ivamectin causes blindness. But they were trying to save your life. So now when you wake up and you're blind from that, your family signs that you are going to take Ivamectin to cure you from COVID. You've cured from COVID, but now a side effect of that at a particular dose causes blindness. Are you going to sue for blindness?
I think the question came from the place of the secrecy. I tried to explain that context because I've heard from someone that part of the purchase agreement is that these major pharmaceutical companies are indemnifying themselves against the governments who place these orders from litigation for adverse side effects.
Yeah. So that one I can't comment too much about because that comes now from, the agreements that they've made. But that again comes with any medication. Again, I'm putting this point. You can open up a Panado, a new packaging of Panado. There's going to be a leaflet in that Panado packaging. And that requires for you to read that fine print before you take 2 Panados. And so you will find that you're a male, and you take the 2 Panados and you didn't read the packaging. That packaging indemnifies the company that actually produced it. So you can go as basic as Panado. So it doesn't only just apply for vaccines, it applies for any medication.
Well,
contract, basically. Yeah. I don't know if I'm answering it correct.
I'm not sure. As I know, Mr. Fanel, no answer will satisfy me at this point in time because with this COVID-19, people are not sure. Dr. Mary, really a very, very, very simple question. And I'm not looking at you now into the Zoom lens, but now at the main camera. So my question to you, and so many people ask this question, is specifically around their loved ones will go into hospital. And most probably not that sick. That's the first one. And then they go for something else. And they pick COVID up in hospital. why is that in the place of safety do they get COVID? There's the first one. The second question is that they don't think that the people were that sick to end up in ICU. Who make that decision between a normal ward and ICU? And because most people feel like the hospital specifically, I cannot speak for public hospitals, but specifically the private hospitals, people feel like they chase the numbers. Because what happened, a friend of ours, whose mother went to hospital, I will not mention the name of the hospital, but it's a private hospital. And then while being there, the first question is, are you on medical aid? Because they want to make a decision, is it ICU or is it a normal ward? And I'm not saying that's true, but they need to sustain the hospital. It's really easy money. And then they ask, okay, if you don't have a medical aid, you have to put down 150,000 Rand right there for 3 days in advance to take your mother into ICU. So then eventually the people didn't have the money, and then they said, okay, come to Nazareth. We're sending you now to Nazareth. All I'm saying, there's a lot of fears out there. What will you say to people out there who they scared? The people are dead sick. They're scared to take the people to hospital because they don't know what's going to happen. They don't have medical aid. They don't know what's going to happen. They also, on the other end, I know I'm asking a whole lot of questions in one, but on the other end, they ill of other type of sicknesses, and they're scared that they will pick up COVID in hospitals. I know there was a lot of questions built in that, but can you just give surety or an answer to somebody out there?
Thank you. I actually appreciate that question because we get that question a lot, and I think people forget that even in a hospital setting, it's a community. It's moving people. It's people. It's a community on its own. And so one thing that I do want to reassure our viewers is that we're not looking for COVID. What we want to do is we want to protect all our patients from COVID. So at the beginning of COVID, or when we put structures in place and our strategies in order to curb and to flatten the curve, we needed to identify those who were symptomatic and those who were asymptomatic. And so we had to create two streams of a flow into the hospital setting. And so how we did that was we had, again, public and private partnership. So we had an area where we could screen and triage high risk and low risk patients. And so those who presented with obvious symptoms, particularly the fever, the respiratory symptoms, we were able to separate them and test them before they came into contact with any patient who was asymptomatic. And so as the virus progressed through time, we noted that there was a group of patients who were asymptomatic but were able to transmit the virus. And so what we did there was so we were testing initially only patients who were symptomatic. And then we moved to the idea of testing all patients who were admitted into our community of patients. And so and now this must be clear that patients who were symptomatic that did not need admission, who were symptomatic with mild disease that we could give them a medication, they could take it home, they went home. So we treated them as outpatients. And then we monitored them through the NICD that went to their homes, did education and that. The next stream of patients were patients that needed admission. And so we created wards specifically for patients who were symptomatic that needed admission but did not have a diagnosis of COVID. So they were coming for other medical conditions. So that those patients, again, did not mix with patients who were already in the hospital diagnosed with or not COVID. Then you had a stream of patients who were asymptomatic, who were coming to the clinics, who needed admission for some other reason. And so those patients were then also swabbed. Reason being is because we needed to know after 48 hours, do you have 24 to 48 hours, are you asymptomatic carrier of COVID? And if you were, then you'd go as a positive patient to a specific ward. So we've done everything in our healthcare system to have two streams of patients, those who are COVID positive and those who are COVID negative. But though, and then what we call the persons under investigation, the PUIs. So they're in the middle. And those patients who then tested positive would go to COVID, and those who were tested negative would go to the general ward. So yes, in the ward where you have the negative patients, because at the time of taking the testing, you might not have an increased viral load to shed the virus. So you might find that you might be still an asymptomatic with low viral load, and as the virus replicates and becomes transmissible, now you're in the general ward and you actually develop the virus. So we've seen this where you then have patients who are particularly waiting for theater or waiting for CT scan, waiting for an intervention. We test them before they go to that, because again, we're moving a patient from one area to another area, and we need to then say, is this patient safe to go to that area? We test again. And we found that while they're waiting in the hospital, that yes, they can either contract it from an asymptomatic patient, or that they themselves were at a low viral load that was not transmissible and not picked up on the swab on the initial. So the thing is, we're not saying that when the patient comes that they're COVID positive, we want everybody to be COVID positive. No, we're trying to protect the public. When it comes to private, I cannot speak to how they run their business, or in terms of the medical aid / money fund and all of that. But what I can say, they also have the same strategy of saying that they've separated wards and they've separated the flow of inflow into the hospital.
I cannot let the show conclude without this question. Is there reason to believe that there is an inflation of the numbers? As a pastor, I cannot tell you that I have in the last 12 months buried someone or attended the funeral for someone who died for something other than COVID. People who went into what was clearly a stroke at home or a heart attack ended up with a COVID death certificate. And there is criticism out there that the numbers are inflated. Would you care to respond to that?
Well, I wouldn't want to say yes or no to that particular thing. What I can tell you is that from the tests that we have based on the national laboratory, that is where we're commenting on. So whoever is inflating those results, or that the public perception that those results are being inflated, that needs to be attended with urgency, because we do not want to be promoting, like we had said at the beginning, we want to be honest. And
we want credible information.
So yes, so I cannot say to you that we are, from a health perspective, inflating, results. I can tell you from the results that are being published, they have to be entered into a database. That database goes to the NICD. These are regulatory bodies. But if anybody is found to be doing that, there should be consequences. And that comes to the question, will there be? And that, is something now that's another legal aspect that needs to happen. And so the one thing that we want to promote is to say that every case that is presented, if let's say the person had a stroke, I'm using your example, at home, one of the things about COVID-19 is that it does cause increased clotting in the blood system. And stroke can be caused by a clot that travels to the brain. So one needs to make sure that one also protects. This is where now we talk about protecting the frontline workers and healthcare workers. What happens is that somebody who collapses or dies at home, when they come in, we do, or at the scene, they need to do a COVID swab for that person to identify whether this person is actually a person that has COVID, so they know how to actually proceed further from there. Because you don't want to expose now the minister. You don't want to expose the funeral parlor. You don't want to expose. That's again a hotspot now. Can you see?
Yeah.
So the number of contacts there.
Dr. Mary, thank you. It pains me to halt you there, but you know what? We can, you as a matter of fact, you should run the inside show. You're so good at it that I think I need you to do the inside show. But thank you so much for your contributions today. But before you run, if you have to run, please run. But if you can hang in there, we just want to have a chat after this. But if you have to, we will not mind, because I know you're on duty. To Mr. Van Nel here, looking at the limited capacity within churches, and what we can or may not open. What's your take on that if it comes to to the churches. And also in line with it, the court challenges by certain church formations to force the different frameworks for service capacity. What's your take on that two questions?
Doc, I think unequivocally we should support, as the body of Christ, the court challenge. The lifting of the restrictions was ill-informed. And I made this point on the last show, that the delegation who engages President Ramaphosa on behalf of the church is really not doing a good job. I want to count my words here. These are senior people. And we want also to be seen to be endorsing how we criticize people in authority. But we have been let down. You cannot lift the restriction and don't have horses for courses. Churches don't have the same floor space. If the issue is social distancing, then align it to a formula that makes sense. We can go tonight to any big Sandton restaurant and find 250 people in the presence of alcohol being available. The restaurant was opened with full capacity. There's no restrictions that apply. Yet, church, it's a safe space. It's alcohol free. Was given 50. Whether you can sit 10,000 people, 1,000 people, or 100 people. So, I fully support the initiative that is currently litigating against the government. I think we must reach out to them and find out how we can support them financially and in other ways and means, probably organize a protest action. If you just look at the drama, the lack of management at the Bait Bridge border post for 2 weeks, that was a greater spreader event than anyone listed by the Ministerial Advisory Committee. So, as a church, I really think we must come to the party, take a stand, and reject this limited lifting of the limitation. 50 people is not working.
There you have it. And I can just speak on behalf of our church. We can handle more than 50 at any point in time. As a matter of fact, we can handle 2,000 people and still have 2 seats in between. So at the end of the day, I'm full agreement. And I don't think the people are doing a good job there in front that's representing the church. I don't think ever they did a good job for different reasons, because they're comfortable for where they are. We are not content because we pray with people, we ask people phone here, people want to come back to church. Yes. People are in financial difficulties, they need help in prayer, they need support. People have family issues, they need church. And those restaurants and all those things cannot supply or support anything. You see, we are spirit, soul, and body. And the church supply the spirituality.
Absolutely.
The body side is for Dr. Mary, which is good, but the soulish side is your academic side, and that is also good. But there's a spiritual side that's connected with your emotions, and we have a belief, and we believe in God, and we want to come to church. All we say is be fair, give it a percentage base. If you're all they need to say is, this is your building. Take 50%. Yeah. Done deal. So don't say take 50. Base 50%. Base it on a percent. That's yes, what we say. Well, unbelievable. Time has passed. Neil Atzenberg, thank you so much for joining us. Thank you for all the questions to Dr. Mary. Dr. Mary, just closing remarks from you and then from everybody, and then we'll close the show.
Thank you so much for having me on the show this morning. Very insightful, very productive, I believe. I hope that our listeners and our viewers will continue to engage us on this matter. I don't think we're still far from the finish. So if we continue to work together, strengthening what we do know and finding out more, let's not just sit back, and let's continue to challenge things. Also, another thing, don't fall in the trap of accepting false rumors rumors or taking anything just at hand. Research it for yourself. Get to know what the facts are. That will help you a great deal to reduce anxiety. With Dr. Carl, we actually talked about vaccine hesitancy some time ago. This was a good couple of months ago. But certainly I'm at the point of, after doing my research, looking at what is currently available, I'm certainly saying that I am willing to get vaccinated.
Thank you so much, because there were a lot of questions, even from your side as a medical doctor. Thank you so much. Neil Assenberg, any closing remarks from your side?
Well, what I want to say, what we started out, and I think Mr. Vanel opened that up. In fact, Dr. Mary opened it up very well, and Mr. Vanel just bolstered the fact is that there's a need for honesty, for transparency, and dialogue with regards to what we are faced with around COVID. And I think from not my appeal, but I think what the country is asking for is for government to be clear and give clear direction and be decisive and not use excuse upon excuse to cover up what they have lacked in supplying to the communities.
Yes. Mr. Vanel, again, always as usual, these days you co-host, you're not a guest anymore on this program. So, but thank you so much for coming. Really appreciate you and your contribution. You add such great value to the show. Closing remarks from you.
Dr. Hendricks, I'm concerned way too much energy has gone into the vaccine. It is not a silver bullet. It is not panacea. We must also look at the other things. The same public health infrastructure that is obsessed with vaccination has got a 37% vacancy rate. We have not appointed doctors and nurses and healthcare workers. We must address the management issues of the economy. We must drive economic recovery. I'm afraid in our cabinet, there's not enough champions of getting the economy going. We may be at a point in 1 year where the people in this country who are unemployed are more than the people who are employed. We're going to run out of cash. And the absence of those things featuring in the national debate concerns me deeply.
Well, that's a mouthful. Thank you so much for your contribution. Well, from our side, can you believe it? We at the end of a wonderful show again. Tomorrow we'll be back online here with you at 9, and we're going to have somebody in the studio that will help churches to get onto the platforms, and we will show some churches how to start from scratch and build it up to what you need to be relevant with the physical and the digital side, which we call the phygital church. That is to be relevant out there towards your communities and to make great massive inroads. We need the church. You need God. You need spirituality. There's no two ways around that, because it's not possible to get through these difficult times without God. One of the reasons why we need church to increase the numbers from 50 to more is simply because, as Dr. Mary mentioned earlier, there's a possibility for a third and a fourth wave. We cannot stay away from church. It's an evil attack, I firmly believe, from darkness to keep us away from the church of God, to fall into a trap where you don't need God. And we need God. I tell you, we need God more than ever. They want to push us into, it doesn't matter who's responsible for this, but clearly there is no room for God in decision making. Well, from my side, please be so kind to subscribe. Be so kind to hit that bell, because you will every single time know when we come online. From my side, I love you and God loves you best. I'm signing out. Take care. Have a super wonderful Tuesday. Till tomorrow. Goodbye. Good morning, everybody. It is so good to have you here with me.
Imagine if you have your vision as the car with the right team.
Imagine how quick that vision will come into the footsteps. Something that was taking 5 years takes 3 months. This morning is all about the leadership and influence.